Okay, we're going to look at the first chapter from Wong's Essentials of Pediatric Nursing. This is Perspectives of Pediatric Nursing. And the World Health Organization says that health is not simply an absence of disease. And for me, I like to picture this as multiple continuums. You have your physical continuum, and you can have a child who's quite unhealthy. They're in the hospital with some physical problem. But if they're feeling safe, they trust that you're not going to do painful procedures without warning them, they're mentally doing okay. Their family is there, the family is supporting each other, coping well, they may be very healthy socially. So that's my picture of health. It's not just a single continuum, but there are many other factors that impact how you're dealing with an unhealthy situation. So what kind of issues do children have? Well, anymore, we're seeing a lot of obesity. We say we have a childhood obesity, and we're seeing type 2 diabetes in children. We used to call it adult onset, and that just doesn't work anymore because we are starting to see it in children. We're eating at less high-fat, high-calorie foods. We're having more sedentary lifestyles, and that starts with children. Kids get injuries. Your toddlers, bump their heads onto things. Your older kids are maybe breaking wrists as they're skateboarding. Your teens are doing, more dangerous activities and have injuries that match those. Violence is an issue affecting children. Many live in violent areas, or they live in families where substance abuse is a issue, and mental health problems. They say 1 in 5 children has some sort of mental health problem anymore, with ADHD being the most common of those. But it is a big and a growing issue. So as I said, how we eat has a big impact on that childhood obesity. So that was morbidity, what kids get sick from. This is mortality. How do children die? And they give this as numbers of deaths per 100,000 live births. So when we're talking about infant, we're talking about the first year of life. Neonatal is the first month of life, for the first 27 days, and then postnatal, but infant is from then up to 1 year. So the biggest predictor is birth weight. When we have low birth weight or extremely low birth weight babies, they have a much higher risk of infant mortality. Some other risk factors: ethnicity. African Americans have a higher risk factor for infant mortality. We lose more male babies than we do female. Babies who are either born very early or go considerably past their due date, higher risk with that. Maternal age, again, younger and older when you're at the extremes, higher risk with that. And then maternal education. Along with that is likely to have been, did they get prenatal care? And the lower the education, the more likely they did not, and that contributes as well. So what do kids die from? The big thing we said was extremely low birth weight, and then after that, congenital anomalies. So kids who are born with problems. We also have SIDS, usually in the first 6 months of life, but in the first year, and then unintentional injuries. So, and here's a picture of a baby playing with plastic, which they shouldn't be. Childhood mortality. So this is children over a year. The leading cause of death is motor vehicle accidents. After that, things like drowning, burns, firearm, poisoning. Kids don't intentionally drink or eat poisons, but when they're sitting around, they think the pills are candy, they think the liquid is juice, so that happens. Preschoolers love to imitate what adults do, And it's amazing what they pick up, the little details, like taking the keys out of the purse, putting them in the car, turning the car on, put it in reverse, and automatic cars will roll once you turn it on, right? Water is always a concern, whether it's a swimming pool, a bucket, a toilet, a lake. Kids need to be watched around water because water's fun to play in. And burns, you can see how just a moment of inattention, how easy it is to cause a burn. Firearms, kids want to play with it but don't understand the safety rules, and a young child with a gun is very likely to accidentally kill themselves or kill someone. So, morbidity, so not mortality, but what children get sick with. We're talking about any kind of sickness. It can be an acute or a chronic or disabling condition. And this is difficult to really do statistics on because most kids get colds and flus that they don't see the doctor for. So how do you really keep track of that? Are you talking about only things that are hospitalized? Are you talking about every little cold a kid has? How do you track that when no doctor has seen them? So it's difficult to come up with exact numbers on this. But again, we know there are certain groups that just have more childhood morbidity. There's more illnesses. If they're homeless, poor, chronically ill children, their resistance just isn't as good. Foreign-born adopted children tend to have low resistance. And then children who are in daycare get exposed to more things and they get sick more. So one thing we really want to do is family-centered care. The family is the constant in a child's life. You can be the best student nurse they've ever had. When you finish the program, you can be the best nurse they've ever had, but you go home at the end of your shift. They may have a wonderful teacher, but that teacher's only there during school and changes year to year. The one thing that stays constant is their family. And so we need to consider that as we're giving care to children, that the family needs to be there. Regardless of what a good job we do, we're going to leave. The family's going to stay. So make sure the family's involved, that they understand what's going on. They're not just extra people. They are part of what we're doing. We're making sure that they know what's going on and that their needs are met. When you think of a family who may have 4 or 5 kids and live 2 or 3 hours away from Valley Children's, we need to help that family to lower the parents' stress, to lower the anxiety of the other children in order for the hospitalized child to heal and improve as rapidly as possible. So they are part of our patient. It's not just the hospitalized child. So we're going to try and help support, respect, and encourage and enhance the family, and the needs of every member is addressed, including those siblings who are at home worrying and imagining far worse than is actually happening to their sibling at the hospital. So how do we do this? Well, by building that therapeutic relationship, just like you try and do with all of your patients. So we need a meaningful relationship, but with well-defined boundaries. We're not part of the family, and sometimes it's hard to keep those boundaries. So we're going to advocate and provide care using atraumatic care. This is another big concept in pediatrics. We're going to do things in the least traumatic way possible. We give very few shots in the hospital, but we put IVs into pretty much everyone. If they can be treated with oral, they're treated at home. If they can't, then we put in an IV. One IV instead of 2 shots a day, it is less traumatic. We also use a lot of PICC lines. If a child's going to be on IV antibiotics for a week, we put in a PICC line. Again, that one invasive procedure is a lot easier than 3 or 4 IV starts, especially if those IV starts took a couple of attempts each. So think, what is the least traumatic, not no trauma, but the least traumatic way to provide the care we need to do. So as a pediatric nurse, we do a lot of teaching. We're going to teach the child and the family about what's going on with them. We're also going to try and do health promotion. What's the next stage the child's going to be in? We need to know their developmental stages and what to expect at each stage so we can tell the family what's coming next. Is it time to get all the little things off of the floor and up high because your child's going to be crawling soon? Is it time to start really working on using safety equipment as they bike or roller skate or whatever activities they do? And pediatrics is not without ethical dilemmas. There are times when it's time to stop searching for or seeking a cure and just go to palliative care. And the problem is we don't always agree with the family on when that time is. And so having some sort of a way to negotiate that is important. At Children's Hospital, there is an ethics committee that deals with those cases. Just like everything in nursing, we really want it evidence-based. We don't want to say, I do it this way because I think it's best. We're going to ask the question, is this way or that way have a better outcome? And then we search for evidence. It may be partly from our own practice, from other people's practice, from the literature out there. There's lots of nursing research being done. Then we analyze that research. Anecdotal research is never strong, right? There's always an exception, and you can find the one person who was the exception. So don't base it on one person's story. You've got to look at multiple evidence, and you've got to analyze it, and then apply those findings to your own practice. And we're also going to always be using the nursing process. We do our assessment, we find those problems, and make a diagnosis based on those problems and prioritizing those problems. Then we make a plan, coming up with the objectives. What do we want to see happen? Maybe we want to see the respiratory rate drop to 20 to 40 in the next hour. We're going to implement our plan, and then we're going to evaluate. Did it happen? Did we achieve what we were trying to achieve or not? And remember, we're going to document it. They say if you didn't document it, you didn't do it. So that is chapter 1.